We're going to take some liberties. We are going to go back and talk a little bit about cardiogenic shock and what door to unload time really means, as well as some other protected PCI applications. These are my disclosures. We know we have a whole spectrum of devices in 2019 and more to come. This is just a limited sample of that. The question is, what do they do, when do they help, and how much can they potentially supply? For a patient like this that comes in with a previous anterior wall infarct, now having a lateral infarct and a left dominant circulation with a starting blood pressure of 70, just opening up the vessel may not be enough. Putting them on hemodynamic support first provides us with the opportunity to get back normal flow and a potential for restoration of left ventricular function. Why? What's going on? The classic PV loop that we sort of learned out in our first year of medical school actually comes back and has significant relevance. Here is antegrade flow being pumped out of the LV, producing a leftward shift in that PV loop, considered favorable from an energetic standpoint and from a hemodynamic standpoint. The same cannot be said for other things like ECMO. Although they provide great perfusion to the rest of the organ system, they put an additional burden on the heart because they're providing an increase in afterload, where here we see our PV loop starts here and then it is moving to the right with the application of ECMO with the pressure that's also included in here, which is detrimental to the vulnerable LV. So we want to go on and be able to make additional improvements in our overall development for strategies. So one of them comes from anecdotal work as well as animal work that's been going on for over 20, 30 years. And that is whether primary reperfusion quickly, door to balloon time has been mentioned, or primary unloading is the best way to take care of this patient. Here's somebody with an anterior wall infarct, had primary reperfusion first, and you can see that there's some thinning of the apex, as opposed to the patient that had unloading first, has maintained that contractility and the thickness of the wall itself with minimal damage. So what really went on? We know from these animal models that go back, as I said, over a decade, that an infarct can be complete, be difficult to restore with an advanced time interval, as is usually the case because patients don't arrive to us in 20, 30 minutes generally. However, if we unload that, we can see that the infarct, though it's still there, has not become transmural on the right by unloading first and then reperfusing that vessel. Just changing the hemodynamics may not be enough. We have to be able to affect the downstream biological results in an issue here that's too complex to go through in 8 minutes, but we want to have the restoration of myofibrils through a pathway that allows us to retain that by unloading the ventricle and producing those long-term effects. All cardiomyopathies kind of look the same at the end. They dilate, they thin, and we want to get to that patient before this happens by affecting these biological phenomena. Bill has already done a beautiful job in his cardiogenic shock initiative going through some of this phenomenal data. You've seen that device implantation pre-PCI is clearly the way to go, at least based on this registry type of data. You've also seen on the right that the earlier this is initiated, the better the patient does as well. So if you think about it, as usual, you should probably go ahead and do it. Some of this has been presented, but this 2x2 matrix is a very simple way of taking a look at this. If your cardiac output is low in terms of the 0.6 cutoff and your lactate is high, then your survival rate is down to 30%. If you can maximize that by lowering your lactate rates and increasing your cardiac power output, i.e. by getting to it early and definitively, your survival gets very, very good. So not all cardiogenic shock is obviously the same. Similarly, you have to be able to support that patient for a certain period of time afterward, and this is going to be evaluated by way of the same parameters. If I still have sort of limping along and I've got a high lactate, I've got to escalate care, and I've got to do this fairly quickly. Do I add on ECMO at this point? Do I go to something else? Whereas opposed to when I've got a good cardiac power output and a lactate, I can begin to immediately wean off the mechanical support. The analogy, as you've seen, is almost like what MASH units did to the survival of U.S. troops wounded in the war. We kind of limped along for a while, and then when we could obtain battlefield immediate application for those wounded individuals, there was a survival advantage. Similarly, we can see on the left that we've gone at this 40–50% plateau for several decades, that this can potentially be improved by going at this very early. As a result of that, the door to unload STEMI safety and feasibility pilot trial was recently presented, and this is underscore safety and feasibility, because what's being asked of the investigators is to take this anterior wall infarct, not in shock, and either wait 30 minutes, putting in an Impella before reperfusion, or just going through standard, opening this up and taking care of them in a traditional manner. Now, 30 minutes is an eternity for an interventionalist. So this is really putting the brakes on, but they had good compliance in this feasibility trial. What they were able to show rather remarkably was the more area of potential ischemia, the infarct area at risk, the larger that became as we move to the right here, the better differential there was between those people who were unloaded first and those people who had traditional angioplasty. So rather a dramatic effect taking place. Well, there's a price to be paid as well. There's a 53-minute on average interval between opening them up and putting in the device, waiting 30 minutes, and then opening them up. Clearly, that's going to affect mortality. It can't be good for the patient. We can anticipate what that mortality is going to be, at least give you a theoretical calculation based on the additional 53 minutes. So what we looked at, what was obtained, that was the expected in the box, and to the right on the bottom in the blue is the observed. So instead of going at a higher rate mortality, it actually went to a lower mortality. So very interesting. What about the remodeling, the end stage effects that we initially alluded to? Can we change the biology to the point where we can actually improve our end systolic and end diastolic volumes? It turns out yes. In blue, again, we have the patients who were unloaded. You can see that their end systolic volumes are lower, and as well as their end diastolic volumes. So this is a ventricle that's unlikely to dilate and go into its end-stage cardiomyopathic process. So very encouraging data, enough to the point where they've been given the go-ahead by the FDA to do the randomized portion of the door to unload, the STEMI pivotal trial, with the same sort of randomization is going to take place, looking at these two different strategies. So we now have the shock doc type of approach where a number of different people are involved. Our surgeons are intimately involved. When they land in their unit, they often get ECMO, followed by Impella. When they land in a CCU, they often get Impella, followed by ECMO, depending upon what kind of escalation is required. So this is really a collaborative arrangement between all of us taking care of these sick patients. So that's sort of the cardiogenic shock unloading picture. What about what's going on with other patients who are having protected PCI? As per the title of the talk, they represent, as you see in the classic Venn diagrams, of overlapping comorbidities, complex coronary disease, hemodynamic compromise. And what we see is was something that doesn't sound intuitively obvious, and that is the more vessels we treated, the better the overall endpoints were in terms of adverse events. You usually associate more vessels treated, more adverse events, because there's more things that can go wrong at that individual site. So this is rather an unexpected finding when PROTECT 2 was analyzed and broken down. Furthermore, we see a significant group of people who have a substantial improvement in left ventricular ejection fraction. When you're starting with a low EF, there's a significant increase for most of these folks. It often gets them out of congestive heart failure. It often even reduces the need for an ICD as a result. So this is also a positive benefit. And we're trying to go and compete with surgical type approaches, as has been mentioned previously. Without complete revascularization, we don't have that capability. And so the more we can potentially revascularize, the better our survival is. And these people that are impaired in this situation and complex anatomies like we see Dr. Keeney and Dr. Sharma do today may not be feasible to obtain that goal without some degree of hemodynamic support. So what they can do, this is a nice compilation, sort of side by side. Balloon pumps at best, you're looking at 0.5 liters per minute, and that diminishes significantly when the patient's LV function declines. Remember, the only thing a balloon pump's pumping is helium. It doesn't pump for the heart. It just changes the hemodynamic conditions, the loading conditions, and the afterload to augment blood flow. As the heart fails, this works to a much less degree. And if you're tachycardic and if you have an irregular rhythm, it doesn't work well at all. But it's simple, easy, and doesn't cost that much, and it's basically a small sheath size. Impella can handle flows from 2.5 to 5. You may have another one that's smaller coming up in 9 French with 1.5 liters, so maybe a significantly smaller size to handle this. Tandem heart, more for historical references. We don't use it much anymore. And an ECMO, as we described, gives you great flow, but has the ability to increase afterload as a result. Those parameters are seen here. As you can see, ECMO produces a great deal of afterload increase. Balloon pumps and Impella do not. Mean arterial flows are increased by all of them, cardiac flow as well. Power, LVEDP, That's debatable because in ECMO, some people go into pulmonary edema as a result of this, afterload increase. And coronary perfusion, not seen in the latter two here, but they are seen in balloon pumps and Impella, with myocardial oxygen demand being improved the most in the Impella. That's the shift of that PV loop. That's what that means. It's a reduction in myocardial oxygen demand. So ECMO has these adverse events taking place in terms of the ability to recover the failing heart. Comparison of the devices in terms of being able to put them in, most of them are fairly quick, exception of tandem heart because it requires a transeptal. The cost, balloon pumps clearly the cheapest. The rest are fairly comparable as well. So our conclusions are AMI cardiogenic shock mortality has remained unchanged for a prolonged period of time over decades, and we're now starting to see an improvement in those outcomes. There's a wide institutional variation of outcomes with Impella use, but the things we've been able to derive from some of this and other data is that the reduced exposure to high-dose inotropes is beneficial. Impella use prior to PCI also appears to be beneficial. We haven't shown you this data, but Bill has alluded to it previously. Using hemodynamic monitoring to guide escalation and weaning, very helpful. We're going to see how prospectively unloading the heart before infarcts, interior wall infarcts, and not just cardiogenic shock is beneficial, but the early feasibility trial was very promising. So those protective benefits extend from improvements in ejection fraction, heart failure, getting patients out of the hospital, avoiding AKI requiring dialysis. It allows for patients to have more atherectomy under these hemodynamically impaired conditions. There's a greater atherectomy time that can be done safely and fewer hypotensive events. The complexity of the procedures can be extended, and support for improved outcomes is clearly out there. The quality cost effectiveness also has shown a 52% reduction in readmissions, a 22% reduction in hospital days, and there's an established reimbursement which is quite favorable. So it is truly the rise of the machines. Thank you very much.